death, or called stillbirth. What is the definition of intrauterine fetal death? It is the delivery of the baby with no sign of life after 24 weeks of pregnancy. What about the incidence? The incidence is 5.5 per 100,000 of delivered babies. Is called stillbirth rate. The IUD, it is associated with some condition like advanced maternal age, advanced gestation, maternal obesity, and social deprivation. So the inter-uterine fetal death is more common with these above conditions, but not considered as direct causes. يعني this condition the IUD is more common أكثر شائع بس ما يعتبر كdirect cause of IUD, only association between each conditions. What about the cause of inter-uterine fetal death? يمكن نقسمها إلى fetal cause, maternal cause, and placental cause. Fetal cause, like cord accident, cord prolapse, nose, torsion, thrombosis, or fetal transfusion, except twin pregnancy with monochorionic twin, chromosomal and genetic disease, structural anomalies of the fetus, congenital infection like bacterial or viral infection, anemia of fetal origin, like alpha thalassemia major, which is incompatible with the life, fetal maternal hemorrhage. These fetal cause of inter-uterine fetal death. What are the maternal or what is called direct effect? Like obstetrical cholecystitis, uterus increase in the bilirubin in the last trimester due to the obstetrical cause and due to the hormone of pregnancy, or metabolic disturbance like diabetic ketoacidosis, or reduced oxygen in pulmonary disease like cystic fibrosis, obstructive sleep apnea. Uterine anomalies like Asherman syndrome, which is intrauterine adhesion, which is mainly occur after a uterine curettage, remove the endometrium, so the uterus supply will be diminished. The fetus suffer from deficiency and hypoxia, which lead to intrauterine fetal death. يعني شنو؟ بعض الأنوميات ذات أشرمان syndrome تحدث after aggressive curettage. If there is injury to deep layer of the endometrium, it is called basalis layer. This may lead to the healing the injury by intrauterine adhesion. This leads to decreased surface area for growing the fetus and decrease the oxygen and uterine supply to the fetus. Other cause, antibody production like congenital heart block caused by systemic lupus erythematosus, anti-ro and rhesus disease اللي ناخذه إن شاء الله المحاضرة القادمة. What about the maternal placental effect? أكو بعض الإفكت يكون مشترك between maternal and placenta, like in the preeclampsia, renal disease of the mother, antiphospholipid syndrome, and thrombophilia. In the thrombophilia, there is an increase in tendency of causing thrombosis, while it is an inherited disease. What caused by genetic or acquired disease? Smoking, drug abuse with cocaine, abruption placenta إذا cause of intrauterine fetal death اللي هو حيصير ب separation of the placenta from the decidua lead to intrauterine fetal death, but should we know there is 30 to 50% of intrauterine fetal death cases are unexplained, يعني without obvious underlying causes، رغم إنه راح نسوي كل الانفستيجيشن وما راح نلقى الأندرلاين كوز وهاي نسبتهم كلش عالية تصل إلى 30 to 50%. What about the diagnosis? How can diagnose this case? Presentation is like decreased fetal movement in 50% of cases. أكثر الحالات يجونا إنه يعانون دكتورة أكبر نحس بحركة الطفل أو حركة الطفل بدأت تقل وهي حوالي 50% of cases. Other present when an unexpected finding or accidentally discovered during the routine antenatal ultrasound, which show negative fetal heart activity or with an acute events like placenta abruption. The CTG revealed negative fetal heart sound or present with the rupture membrane complicated by cord prolapse, present with active labor. إذا دول كلهم ممكن يكون presentation either present patient to you with no fetal movement or discovered accidentally by the routine antenatal ultrasound or by CTG or by present with you with vaginal bleeding and placenta abruption or maybe present with the labor pain, rupture membrane with the cord prolapse. The diagnosis must be established as soon as possible by ultrasound, because the fetal death must be diagnosed by ultrasound, not cardiotogography, which is very misleading, because intrauterine fetal death, in this case, the CTG maybe measure the maternal heart rate, consider it as a fetal heart rate. Normally, we can differentiate it between fetal and maternal heart rate by measuring the rate. If 110 beats per minute or above, it is fetal, but sometimes the mother are anxious and lead to the tachycardia confused with the fetal heart rate. So it's independable, and the definite diagnosis of the intrauterine fetal death must be diagnosed by ultrasound. What you can show in the ultrasound? The first is the negative fetal heart activity. Second, oligohydramnios. Third, swallowing sign is overlap of the fetal skull bone because the death if occur for some times. يعني شنو؟ حيكون overlapping of the skull bone يكون واضح على التصميم إذا كان صار له فترة من ال IUD كان recent one. Also we can find the sign of the fetal high drops if it is there is fetal anemia or congenital infection. At the same time should be exclude acute condition by like approach placenta because it's an emergency. A preeclampsia, we should measure the blood pressure, urine analysis to the rule out the significant preeclampsia and albumin in urine. If the cause of intrauterine fetal death it is a abruption placenta, the major sign will be of abruption what? إذا احنا شكينا شو الميجر sign بالإكزاميشن حيشوفونه. There is tender uterus, tetanic uterine contraction, negative fetal heart activity, vaginal bleeding positive or negative, because there is two types of abruption placenta, like conceal one with the patient present without any vaginal bleeding, but there is intrauterine vaginal bleeding, and reveal one present with the above three signs with vaginal bleeding. If you suspect the fetus die for some times from swallowing sign by ultrasound or by oligohydramnios ultrasound, hydroxia, we should send the mother for clotting screening to rule out disseminated intravascular coagulopathy, like complete blood count, platelet count, activated partial thromboplastin time, thrombin times, and serum fibrinogen level. While in one of the serious complications of the intrauterine fetal death, it is disseminated intravascular coagulopathy and should be screened for it. If it is present, should be treated before termination of the pregnancy. If the mother was Rh negative, we must give NTD because massive fetal-maternal transfusion is one cause of the fetal death and may have occurred hours or even days before clinical presentation. If the mother Rh negative, anti-immunoglobulin blood for the killer test, which is a quantitative test for the measuring of the volume of the fetal-maternal transfusion, should be done because the standard dose of NTD cover only 15 cc of fetal blood. So we need maybe increase the dose of antenatal NTD immunoglobulin to the amount of the fetal blood in the maternal. يعني إنه to prevent sensitization in the patient with Rh negative should be give NTD. ولكن the amount of NTD should be calculated after clear test. This quantitative measure for what test? For the amount of the fetal-maternal hemorrhage. Because in the inter-uterine fetal death, we suspect high amount of the fetal-maternal hemorrhage, and maybe the standard dose of NTD is inadequate to prevent sensitization. I maybe need more additive dose of NTD to be given to the patient to cover all the fetal blood which pass to the maternal circulation. What about the management? There is 8 important points in the management of the pregnancy with intrauterine fetal death. Should we know each one? And the first and important one, it is psychological support. It's very important. Second one, investigation for a cause. Third one, mode of delivery should be discussed with the patient, prevent Rh sensitization, suppression of lactation, and postmortem examination for the dead fetus, and follow-up and management for further pregnancies. It is 8 points. Each one is important in the management of intrauterine fetal death. What about the mode of delivery? After emotional and psychological support of parent and family, the aim is vaginal delivery, unless there is an absolute indication for cesarean section. Various strategies used for induction of labor after the fetal death. It is important to remember that complications such as rupture uterus and shoulder dystocia can occur and bench must be safe. يعني حيكون المونيتورينج للليبر as same in the normal labor, in the normal pregnancy, because any complication during the normal labor may be occur also in the labor of intrauterine fetal death, like rupture uterus, shoulder dystocia. So you should save the life of the patient and good monitoring and continuous monitoring for the patient must be. The patient be treated as in the normal labor. So the progress of the labor should be monitored. Only the fetal heart is not monitored. يعني كل المونيتورنج اللي أخذناها بالnormal labor should be done except طبعا الفيتال heart monitoring ما نحتاج هو already fetal death. The third trimester حتى يكون induction إذا كان IUD بالthird trimester induction of the labor by either standard prostaglandin E2 preparation, other method by anti-progesterone اللي هو mifepristone plus prostaglandin analog اللي هو misoprostol. This regime for termination of the labor of termination of pregnancy by induction of the labor. What advantage of protocol mifepristone and misoprostol? اللي هو one it is anti-progesterone and the other it is prostaglandin analog. The advantage of this protocol is the induction time is short. يعني احنا حيكون time from the induction of the labor till the time of the delivery حيكون shorter if you use this protocol اللي يكون combination of mifepristone 200 milligram orally to 24 80 to 80 48 hours before induction, then misoprostol 200 microgram vaginal, then 200 microgram every 3 to 4 hours orally. This regime is important and efficient to induction of the labor for intrauterine fetal death. So, there's some important points should be everyone know about the difference between the normal labor and induction of intrauterine fetal death. The first one, the membrane should be intact as long as possible. Why? Because of risk of chorioamnitis, ascending infection, and sepsis is rapidly occur in the case of intrauterine fetal death. Second one, postpartum hemorrhage, not uncommon, especially when preeclampsia or premature placenta, or there is a prolonged intrauterine fetal death, more than 4 weeks. Also, there is increase of retained placenta because of a prolonged chorioamnitis or repeated small abruption, so antibiotics should be given. Even these 3 points, important points to differentiate difference between the normal labor and induction of intrauterine fetal death. Membrane should be kept intact as long as possible. Why? Because there is risk of infection. Postpartum hemorrhage should be treated by active management of the third stage of labor. Why? Because there is postpartum hemorrhage. It is common with case of intrauterine fetal death. Also, there is risk of the placenta retention in the uterus or an underlying cause ممكن يسبب. What about the investigation? إذن شنو الانفستيجيشن ممكن ترسل patient with intrauterine fetal death? And why? Because there is risk of recurrence. We try to find the possible treatable cause of intrauterine death. There can be divide the investigation for the baby after delivery and despite careful examination of the baby for any structural anomaly, weigh the baby for possible macrosomia or IUGR, and weight the placenta if it is a small baby. أغلب الأحيان هيكون small placenta or morphology أيضا abnormalities that mostly occur in acute condition. Determine the sex of the baby. كل هذا is called postmortem examination. Also, we need pediatrician help, fetal blood for the infection screen, karyotype for any abnormalities, fetal skin for أيضا karyotype إذا ما نقدر نسحب fetal blood. Okay, full fetal X-ray and amniotic fluid culture. Why? For any cytomegalovirus, adenovirus, anaerobic and aerobic bacteria to exclude the congenital infection. What about the investigation of the mother in this case? maternal blood for what? For any infection, autoimmune disease like anti-nuclear antibody, lupus anticoagulant, anti-cardiolipin antibody. To exclude the SLA also may be anti-Ro, anti-lab, thrombophilia screening, hemoglobin A1C for sugar level over last 10 weeks, and never seen for random blood sugar, because random blood sugar may return to the normal of inter-uterine death, so should be seen for for hemoglobin N1C. There is bile test to exclude intrahepatic cholestasis. Clear test regards the blood group of the mother and should be done as soon as possible. Otherwise, fetal RBC will be rise disappeared from the blood. Anti-Ro antibody if the fetus is high drops. SLA محتمل يكون maternal genital tract swab for what about يعني احنا mother investigate and examine baby also for placenta to know the cause of this condition. The placenta should weigh the placenta, swab for infection, أيضا sample for what for the karyotyping. The whole placenta should be sent for histopathology. Why? To know the any calcification or thrombosis. This important investigation. What about the lactation? أكثر البيشنت after delivery of inter-uterine fetal death نعرف حسب ما أخذته بالphysiological changes in pregnancy after the estrogen decreased after delivery. This resource مالتها طبعا from the placental pregnancy. The milk will be ejaculate from the breast, and in this condition there's no baby, the baby died, and this may lead to the engorgement and mastitis, so should be from the first day after delivery should be suppressed the lactation. This by simple measures and analgesia, because the breast engorgement is a painful one. Okay, also can use a single dose of gabapentin, تجاري Dostinix, to a long-acting dopamine agonist, highly effective to suppression of the lactation. But this gabapentin is contraindication in patients with a preeclampsia because may be lead to the fit, and person or strong family history person of thromboembolic disease also may increase the risk of thromboembolic events. The last point in our it is follow-up. How can follow up the patient? Also, we end by start with the psychological support. حيكون تبوا يا ماما psychological support مهم جدا in this condition. حيكون بأول نقطة in the management of the patient present with intrauterine fetal death، وحتكون أول نقطة بالmanagement patient another visit الأخرى تجيكم for follow-up. فإذا شو وقت حيكون first follow-up visit should be during or after first 6 weeks اللي بلا بنتخصص باليوم. The investigation should be repeated to identify the possible cause and follow the previously set plan. يعني حنشوف نراجع نتائج الانفستيجيشن اللي سويناها سابقا وننسى إذا احنا بدنا نعمل diagnosis مالتنا. If we don't reach the cause, we consider the next pregnancy is high risk pregnancy. إذا يعني شنو؟ إذا احنا ما لقينا الكوز رقم الانفستيجيشن اللي سويناه يعتبر ضمن ال 30 to 50% of unexplained intrauterine fetal death ويعتبر next pregnancy high risk pregnancy to maybe there's recurrence of this condition in the next pregnancy and ended with also intrauterine fetal death. أكو نقطة مهمة أتطرق لكم إياها على ال DIC. What mean DIC؟ اللي هو disseminated intravascular coagulopathy and why occur in condition of intrauterine fetal death. A state is characterized by degrees of decreased fibrinogen. أكو راح يقل fibrinogen, plasminogen, antitrophin 3, and the platelet, and there is increase of fibrin degradation product. It occurs through pathological activation of the clotting cascade, which is demonstrable and within 48 hours of demise. إذا شوف تبدي هاي الحالة ورا 48 ساعة after death of the fetus حيصير activation of clotting cascade. بالنهاية الاكتيفيشن حيقل نسبة الفايبرينوجين والبلازمينوجين والانتروثرومبين والبليتلت وفي نفس الوقت والانكريز الفبرين ديجراديشن برودكت. يعني حيكون اتجاهنا باتجاه البليدنج وليس الثرومبوسيس. The incidence of its increase with the duration of delay. كل ما تأخرنا بالديلي بالtermination and induction of labor in the pregnancy with intrauterine fetal death حيكون نسبة حدوث DIC أكثر. Less than 2% of these women experience a hemorrhage complication and coagulopathy resolved within 48 hours after delivery. And if this condition occurs, should be replace the platelet, the fibrinogen, and should be prepared plasma cryosurrogate fresh blood for this patient because the IC is bleeding from anywhere from her body, maybe also intracranial bleeding, intra-abdominal bleeding, and this fatal condition does not treatment يعني good. Okay. أكو عندكم سؤال مع المحاضرة؟ أكو سؤال ماما؟ فهمتوا هالمحاضرة؟ أكو بوينت يمكن نعيد لكم إياه مقطع نتناقش فيه. Any question؟
شكرا دكتورة، إن شاء الله معك سؤال.
واضح دكتورة إن شاء الله.
إن شاء الله. يلا ماما بالتوفيق. شكرا.